மாறி இது பண்றா என்னடா பண்ண எந்த இது இருக்கு பாரு வெளியில லைவ் பிராட்காஸ்டிங் என்ன ஆகும் அப்ப? ஹாய் டாக்டர். Hi doctor, how are you doctor?
Hi Ravi, how are you? How come I am seeing like myself in two different screens? What's happening? Hi Dr. Robin. Good morning.
Live is a live doctor.
Okay, that's a live screen.
Yes doctor.
Got it. So welcome Dr. Robin. Very nice to have you here today.
Good morning. Good to see you again, Vandana.
Likewise. So I think we have the IT team here, Ravi.
Yes, doctor.
So yeah, well, but I'm glad that all the healthcare workers at least got it, because I think they're the ones at most risk. So my brother is he's a radiologist in Tennessee. He got the Moderna vaccine. I don't know which one you got, but
I got Pfizer. My wife got Moderna, so we're very equal family.
Right. With him, he got. Okay. Hello, everybody. A warm welcome and a very good evening to everyone. We are privileged to have Dr. Alan Robin with us today. His positions, contributions, honors run in several pages. However, for sake of time, I will introduce him briefly. And thereafter, he will be taking us through his presentation on a very, very important and an interesting topic on microincision glaucoma surgery. I will request everybody to start penning down their questions that you would have for Dr. Robin and for our panelists today into your live board, and we will receive those questions and we'll make sure that we get those questions addressed appropriately. To introduce Dr. Alan Robin briefly, he's a leader in clinical management and scientific study of glaucoma, and besides that, also in the global impact of eye care. Currently, he holds joint associate professorship in ophthalmology and in international health at Johns Hopkins University, and he's also an adjunct professor at University of Michigan. He's also the executive vice president of American Glaucoma Society. He has been the co-director of glaucoma services at the Greater Baltimore Medical Center. Additionally, he is also the professor of ophthalmology at the VA Systems and has been actively teaching optometrists as well as ophthalmologists. He has trained many fellows and residents who are currently serving as department chairs. Besides that, he has also trained 12 international fellows. He has done several studies and he's recognized leader for the impact in global health. He was the first to evaluate and report on the success of ECCE and intraocular lenses in the developing world. He developed a portable Nd:YAG laser for the treatment of angle closure glaucoma in the developing world. And he was the force behind the development of novel drug, apraclonidine. He worked closely with Arvind Eye Care System, and they have performed numerous research studies together along with Arvind Eye Care Systems. He has also worked with Aurolab, and he was responsible for development of low-cost surgical glaucoma drainage device. He has worked as a consultant to FDA, as well as consultant to many pharma and device companies in an effort to develop protocols and solve key problems that industry is facing. He has numerous publications and research to his credit. He has won numerous awards during his career. Among them, the Senior Honor and Secretariat Award of the AAO, the Outstanding Humanitarian Service Award of the AAO, Dr. Venkatswamy Oration Award, the American Glaucoma Society Humanitarian Award, Silver Achievement Award of the Associate of Ophthalmology and Visual Sciences. He is somebody who's known both in the US and globally for his work. His current research includes the use of newer delivery systems for medications to treat open-angle glaucoma, innovative collaborative screening devices for glaucoma, as well as diabetic retinopathy. And he's deeply involved in both the global eradication of needless blindness and establishing strategies for better care delivery in collaboration with Arvind Eye Care in India and Telangana Eye Care Center in Nepal. A very warm welcome to you, Dr. Robin, and thank you for making time to educate us today. Over to you, Dr. Robin.
Oh, thank you very much, Vandana. That's a very kind introduction. Let me get to my slides, share, and let me do, there we go. Can you see my screen? I would hope so.
We can, okay. Dr. Robin. Please go ahead.
I'm going to start. I'm going to talk about MIGS and its current state. I think that's an important way of looking at it, where it is, and I'm not going to talk about the future, but I can answer that in the question and answer period. My presentation will be based on facts. The American Glaucoma Society in the journal Ophthalmology Glaucoma produced a white paper, shown here, of which I was a co-author, discussing MIGS, or microinvasive glaucoma surgery. And so I have no financial vested interest that it would at all impair my ability to fairly discuss this topic. And I think that's very important. Many speakers sometimes are paid by companies, and I have no financial disclosures. My only salary is from the American Glaucoma Society. So let's talk about basic definitions. Before we get anything more advanced, let's talk about things. The Food and Drug Administration in the United States talks about aqueous shunt devices. And one of the initial hardships in developing MIGS was going away from this. Shunts thought of before the primary tube versus trab studies was something for failure. People who are uncontrolled by medical therapy, but also failed incisional surgeries like trabeculectomies, failed diodes, had conjunctival scarring, had neovascular glaucoma. You're thinking of shunts, the conventional way of thinking of them, as devices for failures. MIGS, on the other hand, are devices with little or no conjunctival scarring. These are devices for earlier glaucoma. And as was pointed out before by someone, in India, and in my experience in India, it's very rare to see somebody who has very early glaucoma. Most of the people you will see are people who have very advanced glaucoma, who really need desperate IOP lowering. And we'll talk about that, but I think that's a very important thing for you to keep in the back of your mind. The development of MIGS dealt with some regulatory hurdles and issues. If you look here for the aqueous shunts, they were 510K'd. What's a 510K? It's like if you develop a new intraocular lens, you don't have to go through all the whole regulatory approval system and all the new development. It's basically saying, are you as effective as the last dial IOL with a green haptic, not a blue haptic, or a polypropylene haptic, or a one-piece IOL? Are they equally safe and equally effective? So it's pretty easy. You have to look at a standard. The development of the iStent, which was really the first MIG development for early non-refractory glaucoma. And one of the issues we're facing now is working with the FDA, and I'm on a panel trying to redefine refractory, and that's another issue. Had a PMA, or pre-marketing approval, and it means that you really have to go through everything, safety, efficacy, and all that. And one of the key things they did to make it easier for Glaukos, which makes this, was to do it in combination with cataract surgery. So whatever the risks were with cataract surgery, and we all know those of broken capsules, of endophthalmitis, hypotony, CME, were basically already covered by cataract surgery. And the question is, did this have any more risk? And it turned out it did not. What was the climate in which MIGS was developed? This is some of our work from 2014, looking, and you can see here that the rate of shunts, Barvelts, Multinos, Ahmed, was tremendously increasing over an 8-year period. Likewise, revision was increasing, but not to the same extent. But the scale here is 2,000 each. Here we have 10,000 each. And this is the total number of trabeculectomies, which is dramatically decreasing. And this is the number of complex trabeculectomies and scarred eyes, which was staying about the same. And why the change? Sorry about that. Why the change? I think the reason is in most people were doing cataract surgery. Cataract surgery had changed from extra cap to phaco, or small incision cataract, where there's really no sutures. And so the art of using a suture was lost. In addition, cataract surgery, which was increasing, had happy patients. You took somebody who couldn't see, and you made them see better, see happy. And they all loved you and hugged you and kissed you, except in the COVID period, they were very happy. With trabeculectomies or valves, with diplopia and all that, that didn't happen. You look at change in attitude. This was an American Glaucoma survey, American Glaucoma Society survey done in 2016, so 4 years later or 6 years ago. And you can see that their first choice of surgery had diminished for trabeculectomies, had increased for drainage valves, but had markedly increased for MIGS, from nothing to, it should be 2013 to 2016, not 2018, but remarkably increased. So I think the attitude wasn't changing. People were sick and tired of complaints, of had happy patients, and were looking for a better surgery. if you look at the primary tube versus trab study, you can see that there were a lot of failures. And not only were there a lot of failures, but and here you can see something that I think is very important, and this is not totally germane, but I want to point it out. If you look at the success rate of tube versus trab, they look about the same. But if you break it down, and I think it's very important whenever you look at a study to look at the actual results, it depends on the IOP range for how successful these are. If you're looking at low IOPs, tubes seem to be more successful than trabeculectomies. In those with higher intraocular pressures, trabeculectomies appear to be more effective than tubes. Trabeculectomies are the dotted lines, the tubes are the solid lines. So I think that's important for you to think about when you start analyzing MIGS data also, is what kind of glaucoma did people have and what were the IOPs at baseline. So what are the complications associated with our conventional surgery? Regrettably, we know them all: encapsulated bulbs, dysesthesia, people were unhappy, their eyes felt worse than they did beforehand, even worse than with drops. There's diplopia, CME, wound dehiscence, plate erosion, vision loss, more surgery. I mean, you're dealing with an unhappy group of patients on the whole, yet if you did nothing, they'd go blind. These are the complications that made you really stop and think. The encapsulated blood, the CME, the suprachoroidal hemorrhage, the horrible Dellens, the flat chambers. These are things that made you stop. So let's get into what's happening. So what about micro-invasive glaucoma surgery? This is why it was started. Glaucoma is a surgical disease because people don't take their medicines. For those of you who've seen my lectures, they don't take their drops. They can't get them in their eye. Even other people have trouble getting drops in another person's eyes. So perhaps there's a better way of doing it. This is a way of improving outflow with minimal conjunctival disruption. Okay? Now, what I like to say, and this is very apropos to both our audience in the US and to the Indian audience, is it really MIGS, minimally effective glaucoma surgery. And well, one of the things we have to think about is the clinical versus statistical significance of the data. That is, it may be statistically significant, but does it really make that much of a difference? Is the IOP lowering worth the potential risk of a surgery or the cost of the operation, unless you are interested in just the money? So why MIGS? Okay, adherence is a major issue. So in patients who have problems adhering, who have earlier glaucoma, this is a great thing. People who are on 3 classes of medicines, if you can get them down to 1, we know that the more drops you're taking, the more likely you are to not adhere. People who forget to take their drops, cannot get the drops in their eyes. People who can't go to because they're older or don't have family members who can go to get their medicines for them. This is also important. And the cost, even a few rupees for some individuals, may be too much. And you have to weigh the dependence on drops, the risks of hypotony, suprachoroidal hemorrhage, endophthalmitis versus the potential effect of the MIGS surgery. So who should get this? This is somebody who has early glaucoma, slowly progressive, some problems with adherence, requires cataract surgery, on 1 or 2 medicines. This is a perfect patient to try your first MIG on. In my practice, there were very few patients like that. My practice is totally referral, so I would have like an Indian practice of very advanced glaucoma. Who should you not do it on? Somebody who has central visual field loss, who has advanced damage, who's rapidly progressing. This is somebody who really needs conventional glaucoma surgery. Let's talk about canal-based surgery first. These are smaller incisions and they enhance physiologic outflow. Remember that whoever devised the trabecular meshwork was pretty smart. He or she realized that only 50% of the resistance could be removed if you remove the whole trabecular meshwork. This helped prevent against hypotony. So if you want to know how much you can get out of a procedure, you have to remember this. You can't eliminate all of the resistance. Before you do your first canal-based surgery or MIGS, make sure you know how to do gonioscopy. So a refresher is free. A friend of mine, Lee Allward, who's also a friend of India, did in his own spare time this website called gonioscopy.org. It's great. It has examples. It tells you how to do gonioscopy. And for those of you who feel a little shaky about it, this is really good. And I'm going to do a plug for Lee. At the bottom here, there is a curriculum, 50 14-minute courses that deal with all of glaucoma. So for the residents you teach, for you who feel a little shaky on glaucoma, a great curriculum on learning glaucoma. So this is a little ad, free of charge for Dr. Allward. So before you do any canal-based surgery or any MIGS, make sure you know gonioscopy. Know it cold. Then do it on almost all your patients, even if they just need a refraction. After you refract them, do gonioscopy at the slit lamp. After that, on all your cataract patients, do gonioscopy on them on the table so you're familiar with what the angle looks like, how to position the patient, and try doing that. So performing IPAS or Cahook, dual blade, or trabectome may be the easiest initial surgery. Do your first cases in somebody who has a wide open angle so that you are really easy to see the landmarks. Somebody who may have a pigmented angle so that you can see everything. Make sure that you place somebody in the reverse Trendelenburg position so that you minimize EVP and you minimize reflex. And you want to make sure your anterior chamber is always formed. Use whichever viscoelastic you love, okay? The trabectome, somebody mentioned it. The problem with the trabectome is it doesn't work all that well. It does do some work, excuse me, but it isn't the greatest, and it's also fairly expensive for what you do. It is in essence, a pulsed electrosurgery that disrupts, ablates, and aspirates. If you look here, this is what your trabecular meshwork looks like, and you can see in the pictures the differences. Now, regrettably, it isn't the most effective. I have not done trabectomes. I was about to do them, and people who I knew at Bascom Palmer who did it were sorry they bought the machine. I have no financial interest, pro or con, but I think that I would not stay away from it. This is from Devinder Grover, and I think this principle is very good. When you're going to do canal-based surgery, you want to make sure that the episcleral venous plexus is really working. If you inject some fluid with your INA machine, you can see that there's blanching here, which means the collector channels work well. If you have no blanching here, this seems really there, all the vessels are still there. The episcleral fluid wave isn't all that great, and it means that most likely it may not work. So it's a pretty good test. The last thing you want is an unhappy patient. So let's talk about trabeculotomy, okay? And we all think about trabeculotomy as being for kids, and its use for adults is being fairly new. That's not true. The first work by Morton Grant was in 1958, who thought that 3/4 of the resistance of the trabecular meshwork or flow was in the trabecular meshwork, getting between Schlemm's canal and the anterior chamber. So the concept of working on this area really started almost 60 years ago. The work by Redmond Smith in 1969 started discussing the results of basically goniotomy in adults, which is pretty exciting. So what we're doing now is really not something new, but really something that's 60 years older. And it's evolved. It's evolved from using Harm's trabectomes to actually putting a suture in the anterior chamber. And this is the Feldman-Devinder Grover technique. And Devinder has been to Arvind and has taught people at Arvind this, where you basically insert a suture either externally, this was the iScience technique, to internally. I truly believe in this. Let me tell you a story. I had back about 15 years ago, a girl who was like 35 or 40, wanted to keep her contact lenses on, had pressures of 50 on maximal medical therapy, and had no field loss yet, or very minimal visual field loss. She sought me out because I was one of the investigators in something called the eye science, which was you did a scleral flap, found Schlemm's canal, and you then put a Prolene suture all the way around, pulled it, and did a total, basically, trabeculotomy. And I said, well, I'll try it on you. I'm not sure if it's going to work. You're probably going to need a filter. But she had the bit in her teeth, really wanted to have something done that was not blood-based because she wanted to get married and look beautiful with her contact lenses. We did this, and this is now, I just talked to her about a week ago. Her intraocular pressure is on no medicines and has been in the low teens since then. So that's pretty impressive. Dr. Grover's technique in your bottom right is basically an ob internal technique where you insert a 5-0 Prolene suture in the trabecular meshwork in Schlemm's canal, make it go circumferentially, and then you tear it out. So this is the technique. You basically put it in, you make it go circumferentially, and you tear it out. Dr. SYED in Pondicherry at Arvind is doing this now. And if you'd like her feedback, you should probably ask her. Another procedure, and this is from Devinder Grover, is a Cahook dual blade. Somebody mentioned this. This is a comparable thing, but you cannot go all the way around. One of the problems I've seen with the Cahook dual blade is that it basically has, if you're not in the right place, you can create a cyclodialysis cleft. And I've seen many of those, and they're very hard to treat. You basically disinserted in many patients a ciliary body. If it's done well, it lowers IOP about 30 to 40% for about a year or two in many patients. The series are not very long. If you can see here, and when you look at series on MIGS, you want to make sure that you're looking at the right thing. Here you have 71 eyes, followed a varied amount of time, retrospective. In the other series, it's 52 eyes, various forms of glaucoma. There's no mention of severity of the glaucoma. And everybody has different ways of assessing it. They start saying that they take off medicines, and you wonder, do they really need the medicines in the first place? We've all added medications to find that they really didn't work. And some people just continue to add medicines. So I think it's important for us to be critical when we evaluate the literature before starting to do a specific technique. Let's look at the eye stent. Now, the eye stent, I think, is the beginning of real new MIGS. Started 14 years ago. It was the first ever MIGS study. And as I mentioned before, the comparator was the phacoemulsification. So it really gave us some more encouraging data about cataract surgery alone. This is an initial eye stent being placed in the eye in your right-hand screen. You can see that it's a long tube with a snorkel on the end. And after it's removed and tapped in, you can see the snorkel. And that's how an eye stent is inserted. It's not as easy as it looks. It really the population had no terminal washouts. You really don't know when you stop the medication, did it really do better? And the effect was people with no medicines at 12 months. And the second endpoint was a 20% reduction. So this is how well it did. Statistically, compared to the controls, it was statistically significant difference. But the question is, was it clinically significant? Would you like to spend $2,000 for an eye stent, or later on put in 2 or 3 eye stents for a 10% change in pressure or a 9% change in pressure? I'm not sure that it's really cost effective or really worth it. Now, there's new MIG data since that, and this is a UBM of somebody who has a iStent in place. You can see that it's in the trabecular meshwork. And this is the iStent Inject, the newer device. And they're now coming out with an iDose, which is basically putting this in the trabecular meshwork and having a reservoir of either timolol or of travoprost, which seems to leave people, it's like having a second medicine or having a second procedure. The effect of putting an iStent in is about having a 20% decrease in IOP, which is a little less than the effect of timolol, if you put it in perspective, or the effect of aproclonidine. So again, this is with 2 iStent. This is from Ike Ahmed in Toronto. You can see that the Medicaid IOP went from 24 to 14 on 2 meds going to 1 med, but the question is, were the medications really tapered appropriately? And from 25 to 17 at 13 months, or a 32% decrease. But the question really becomes of what group of patients these were. These are phakic patients, and what is really going on. The next device I'd like to talk about is the Hydrus, which I think is more effective than the iStent. This is a longer, basically, stent. It goes in the trabecular meshwork, and it's about the same size, except longer as the Glaukos iStent. Here you can see it being inserted. I'll be quiet for a second. You have to sort of point up, because if you point down, it'll go into the ciliary process. You have to make sure it goes into the Schlemm's canal, and you can see it being injected. You have to be steady as you put it in. And I will wait. It's about to be removed. And you can see it now in the trabecular meshwork. Right here, you can see it very easily through the trabecular tissue, and then it's being removed and left in place, okay? The primary endpoint, and this was 369 with phaco and Hydrus versus 187 patients with phaco. Again, this is used in conjunction with cataract surgery. It was done in a multiple study sites, and you can see here the results of the Hydrus. Again, a 15% decrease to 19% decrease, significantly better with the Hydrus at 24 months and 12 months than phaco alone. But again, it's only a 20% decrease. And if you think about it, a prostaglandin lowers IOP about 30%, a beta blocker about 25%, alpha agonist about 20%. So this is like adding an alpha agonist. Likewise, the mean change IOP was 2 to 3 millimeters, which is statistically and clinically significant. But if you have somebody who has advanced glaucoma and comes in with a pressure of 30, I'm not sure this is the right procedure. Their clinical results of adverse events were very impressive. These were big studies, long-term, and as you can see here, except for the device malposition and a hyphema, it's almost no different than cataract surgery, okay? So the next thing that has been done for all of these devices because of the FDA is the quality of life studies. We know from CIGIS, or the Collaborative Initial Glaucoma Treatment Study, that people are unhappy after they've had glaucoma surgery or even after medications. We wanted to see how there was a difference here. And you can see that the quality of life was really not much different after Hydrus than it was after a cataract surgery alone, which is pretty impressive. So let's talk about summing up how to do these procedures. To be effective and get a successful outcome, you have to have atraumatic surgery, which means you have to know your angle. You have to well position the device in the canal. You have to be near a functioning collector channel entrance. Remember we talked about blanching? You have to make sure that the downstream collectors are functional and that there is favorable canal wound healing without scarring. There's no PAS, and to be successful, you need all 6 factors. For a poor outcome or a minimally effective outcome, you have traumatic surgery, a poorly positioned device, a device far away from a good potential collector channel system. You want to make sure that the canal system is working, the collector channels are working, that there's not excessive wound healing, and there's PAS. And so any of these alone could give you a poor outcome. In conclusion, I'd like to invite all of you to join our annual meeting. It's the first time because of COVID that will be virtual, and it will be open to the whole world for the first time. Before this, you'd have to be a specific member, or a member or a guest of a member. Anybody can now register. If there's any problems registering, please contact me. If you go to the American Glaucoma Society site, go to annual meeting, and then go to registration. Thank you very much, and I'll turn the meeting back to Vandana.
Thank you, Dr. Robin. That was a fantastic presentation. It was really amazing. I learned a lot from this presentation, and I'm sure our audience also learned a lot. I'd also like to just briefly introduce our panelists for today. We have two amazing glaucoma specialists who have also joined us today. Dr.SYED HUSSAIN NAQVI, who's a glaucoma specialist at the Agarwal's group of eye hospitals. And we have Dr.ANDREW BRAGANZA, who's a glaucoma specialist at CMC Vellore. Warm welcome to you both as well, and many thanks for making time. So the audience questions will be coming to us now. Of course, I request all the people who have attended this amazing session, and I'm sure you're all bursting with questions. So please write down your questions on your screens, and we will get them addressed by our amazing panelists and the speaker for the day. With that, I'll also open up the panel discussion, Dr. Andrew BRAGANZA and Dr. HUSSAIN. First, I would like to, you both to discuss with Dr. Robin the potential of the minimally invasive glaucoma surgery in Indian context, and what an Indian ophthalmologist can actually think about this particular surgery today and in future.
Well, yeah, I think that's very appropriate, and I'd like to say that Dr. Alan started off emphasizing the need for good gonioscopic skills and to be able to actually use a gonioscope intraoperatively, and I think that's going to be the sort of limiting factor for people attempting these surgeries. It does require a fair amount of skill. But before we go on to the Indian scenario, Dr. Robin restricted himself to actually talking about canal-based MIGS. So my only experience with MIGS actually is with the JAIN implants. So I wanted to know where you think JAIN implants fit in, because it does invade the subconjunctival space. I've found in my very, very limited experience that they do work reasonably well with mitomycin and sort of tend not to work without mitomycin. So where do they fit in? Because they are likely to be marketed soon in India.
Yeah, my experience with, first of all, to make sure, people, and I didn't want to confuse people, there was a device marketed by Alcon called the CyPass. And the problem with this CyPass was that first couple years it was okay, but by the 5th year, I try to remember what percentage, but I think it was 20% of individuals had greater than 30% endothelial cell loss. And for the cornea surgeon, it was a great boon, so you can do more surgery. But I don't think it was the right thing, and the FDA withdrew it from the market. The JAIN is different. Again, you need to have good gonioscopic skills to know how to insert it. My impression is that it required constant laser treatment of the angle because it would clog up and you'd have to reopen it. So it's almost like you're doing babysitting or constant attending to it. And I think it is being marketed almost as a substitute for trabeculectomy, which it really is not. So it's sort of in between a canal. I think it can be as effective as a trabeculectomy, but usually is not, and requires many more procedures, so to speak.
Okay. Yeah, I think that's fairly clear. It's also we have no idea what the price is going to be like in India. It costs over 1,000 euros in Europe, so I don't see them marketing it at less than that price here, which automatically puts it out of the range of most of our glaucoma patients. So coming back to the idea of a financially viable, reliable MIGS procedure, I entirely agree with Dr. ALAN about the proline suture and the ab interno trabeculotomy. As he said, the other group is doing quite a few of these. These surgeries are not free of complications. And I think a fairly high level of skill is required. From the little, unofficial discussions that I've had with a few surgeons who do this procedure, there tends to be a bit of difficulty in the ab interno procedure in trying to pass that proline suture once it's crossed about 2/3 or 3/4 of the trabecular meshwork. So the last bit can be a bit difficult. So there are obviously technical implications, and there have to be some kind of issues some kind of techniques to address these problems. But it does sound promising.
Yeah, I know that Swati went to see Dr. Feldman and Grover, who developed the technique, to watch them operate, and Dr. Grover, has been to Pondicherry. And I think the hard part, you're right, is you have to sort of go back and forth at the end to try to let it go through the whole circumferential area of the Schlemm's canal. But I think if you can learn the skills to do it, it may be a great attribute. And there are problems with hyphemas, but they do resolve.
So let me get it clear. What I'm understanding as somebody who's more layman to glaucoma is that as far as the Indian context is concerned, one, of course, cost is a big factor, as a result of which we are talking more about, proline suture-based ab interno technique rather than using one of these devices, given the cost. But do you think, Dr. Braganza and Dr. Hussain, that there could be other factors, for example, the stage that the patients present with besides the economics that could be at play? And what are we, let's say we actually assume that there is a certain subset which actually can financially afford these devices. Would we still want to do them? And what are those kind of patients that we will actually want to do these procedures on, as far as the Indian context is concerned?
Yeah, a couple of things in terms of the Indian context. First thing is that cost apart, economics apart, in India we see that angle closure disease is equally prevalent, if not less, than open angle disease. So that's another limiting factor. As Dr. ALAN has pointed out in his last slide, that there should not be any PAS if we have to do a good MIGS surgery. So in presence of PACs, MIGS surgery is ruled out, and we have a decent number of the angle closure disease patients. Second factor is the severity of the disease at presentation. Most of our patients who present to us in the clinics are in moderate to severe disease, those who are on 3 and plus medications, more than 3 class of drugs. So in them, if we are trying to do a MIGS surgery, it would not work. We would not be able to achieve the target intraocular pressure what we want with the MIGS. So as far as Indian context is concerned, I would say that the MIGS surgery form a bridge between the medications and the conventional surgeries, like where you have a patient who is having early to moderate glaucoma, those who are on 1 to 2 drugs, and as Dr. ALAN pointed out, that those who are elderly, having some ocular surface disease, where we want to get rid them of the drug and the adverse reactions of the preservative. In them, we can plan to do this MIGS surgery. But if we are looking for a results which are on compared to the conventional surgeries, MIGS are nowhere near to the conventional surgeries. But the advantage which they provide, the advantage which they provide is that after doing MIGS, we still have a virgin conjunctiva to do the second surgery in case it be needed. But if we are directly taking up the patient for the trabeculectomy or for aggressive surgery like a valve, then the next procedure would be only a cyclodestructive procedure.
Yeah, I think.
Okay.
Sorry.
No, Dr. Braganza, please go ahead.
Yeah, those points are well made. About half our patients are going to be ineligible for MIGS procedures because they are angle closure patients. This is strictly applicable in the current process of thought to primary open angle glaucoma. I mean, that's where it's been studied, that's where it's been applied. Possibly secondary open angle glaucomas also, there may be a role for MIGS, I don't know. I have heard it advocated that these ab interno goniotomy procedures should be done in angle closure patients because the iris is adherent to the trabecular meshwork, and when you go and rip through the trabecular meshwork, you actually release the synechiae and you address the mechanism of the glaucoma. I've heard this very seriously recommended, and I'm not sure, you know, I'd like to keep an open mind about it, but I'm not sure that that's entirely appropriate. We are, I think, now in you know, the same stage that phaco was in about 30 years ago. The 90s and early 2000s were the era of what I call phaco cowboys, that, you know, phaco was a new technique and everybody wanted to do it on the most difficult cataracts. And we still have a lot of videos and presentations on, you know, how to do phacos in subluxated lenses, and how to do phacos in matures and hypermature cataracts, and how to do phacos in almost any situation you can think of. How to do phaco with your left hand, with your right hand, standing on your head, all that. So, and that's, you know, I mean, it's a challenging surgery, and one can understand the excitement of the surgeon in trying to overcome this difficult technical challenge. And these surgeries have these mixed surgeries have the potential to be equally challenging for the glaucoma surgeon. So I think that, you know, the 2020s is going to be the era of the glaucoma cowboys. And we're going to see a lot of appropriately and inappropriately applied surgical techniques over the next 10 or 15 years. And hopefully this will eventually, you know, come down to clear indications of where these procedures can be advantageous and where they should be strictly not recommended. And I think that we are going about it correctly because we are discussing a lot of these things. We are keeping an open mind. I think we shouldn't be too critical. We should be prepared to you know, acknowledge that thinking out of the box may work in some cases, but we need to be very open about things and also make sure that all patients are reasonably protected as far as experiments in surgery is concerned.
Yeah, I agree with you, and I think a point that should be made is that this is like, I'm old enough to remember when IOLs were first begun, and there were Sputnik and iris claws and all kinds of weird things that were the greatest thing one year and then horrible and malpractice the following year. And I think this is an exciting time for glaucoma, and this is the introduction of a new train of thought. Is this right for everybody? Absolutely not. But neither is phaco, as you well pointed out. But there are things on the horizon. Many people are working on drug delivery through these. There's something called the PreserFlow or the InFocus by Santen, which is something that will be comparable to a trabeculectomy, we think. Okay, I haven't seen the phase 3 data yet, but that would have the same IOP lowering with less side effects or less adverse events. And I think as people start thinking about this, there's Mark Rumanin in California is working on a little device that's like a MIGS that senses your pressure. You can adjust the pressure in your eye. So if you want, let's say you have a target pressure of 16, and that turns out to be too high, you can lower it. Or if you go too low, you can make it higher. So I think this is the beginning of a new era. It's sort of like DISSEC was for cornea with the MEC and DISSEC and all these great new corneal procedures. But you had to start someplace. So I agree totally with you.
So, Dr. Robin, I have a question here. Would there be any difference with the racial difference, like the South Asian eyes versus the Caucasian eyes? Would there be a difference when it comes to the use of these devices, given that we have more pigmented eyes, and can it lead to more blockage and things like that?
Yeah, it's interesting. In my experience in India, and I have a fair amount of experience, I have not seen more darker trabecular meshworks than in Caucasians or in African Americans. It's hard to gauge preoperatively. In the studies that are done in the U.S., when you look at racial differences in African Americans versus Caucasians, there aren't very many Asians. I have to be very honest. There has not been a racial difference, but the numbers of African Americans mimic our population, which is usually about 14 to 20%. So in that series, there has not been a big difference. I've not seen any reports saying that they don't work as well in Asian or heavily pigmented eyes. So I think that has not been seen so far.
Okay, and in your sense, which of these devices may be suitable for a country like India?
Well, I don't think any of them cost-wise. You know, unless you have a very wealthy practice of entrepreneurs or whatever. And there are people who get multifocal IOLs at $1,000 and whatever, and get flax. So there are a group of people who like that. And I think that the Hydrus is probably the best of these. The GAT is really, I think, if you have the skill to do the GAT with the Prolene suture, that may be a very good procedure. It's an inexpensive blebless procedure. And then if it could, you know, one of the questions I think that you have to think about, and nobody knows, and about 15 years ago, I tried to introduce Glaukos to the Indian subcontinent, was if you take somebody who has moderate glaucoma today and you permanently lower the IOP by 3 millimeters, does that increase their functional ability to survive, to have quality of life, to be able to count change, to be able to work on the farms by another 5 years? Is that 3 millimeter difference over years really make a difference? And nobody knows the answer to that. I don't know the answer, and I wish I knew the answer. But I know that for each decibel of visual field loss, there is some functional loss. Pradeep Ramalu, who's also a friend of India, who's the head of glaucoma at Wilmer, has done extensive work showing that even 1 decibel can change your reading speed, your desire to drive, your ability to walk, how much activity you do. So I think it really makes it important to try to keep people where they are. And I don't know if a 2 millimeter difference or a 20% difference long term makes a big difference. I wish I knew the answer to that.
Okay, so one of the audience questions is that which site do you choose when you opt for multiple stents, and how do you decide that?
I think, you know, you have to think of surgical approaches, and most people go temporally. So I think that one of the issues that you have to do is to go for your temporal approach. Most of the eye stents in a left eye would go from 8 to 11, okay? And then from a right eye would go from 2 to 5.
Got it. So it's more about the approach in each eye. So we have another question from Dr. Manjula, that please provide us some tips to locate the Schelm's canal while threading the Prolene suture during the surgery.
My suggestion is to go to the gonioscopy.org. There's some great, I don't know if I have that up. I don't, but let me see if I can find it for you. Here it is. Let me share my screen. If I can do that. Is my screen shared or not? No.
Okay.
Not yet.
Not yet. Gonioscopy. Can you see that? And basic techniques, general technique, 3-mirror. There's some wonderful techniques in gonioscopy.org.
This sequence will show general exams.
I don't want to talk. Examples of introduction to gonioscopy. There's all kinds of wonderful, wonderful examples in here. Let me see, examples, introduction, where was it? So my suggestion is to go to this website and look through it, but there are some great examples or some techniques on how to do gonioscopy. There's a lecture by George Spade. You can't ask for anything better.
Great. So I think it's very important, like as people, it's this question I think is very important, because I think one of the things that intimidates people is that how do you even begin to start thinking about doing these procedures? So one of the skills that people require are good gonioscopy skills, on which you mentioned that they should practice gonioscopy in literally every patient in their outpatient, as well as during the surgery, so that they get comfortable with the gonioscopy and identification of all the structures. What would be the next steps if somebody wants to actually master this technique, one of these surgeries?
I think the next step is to do gonioscopy on all your cataract patients. Okay, at the end of the procedure, put on a Swan-Jacob lens or whatever lens you want. Practice looking at the angle. Usually you put something in the eye at the end, myostat, or you refill the eye. You may want to put your cannula in the eye and just try to pretend that you're going over the angle, or taking a probe and going over the iris without actually touching anything, so that you get the feel of manipulating what you're doing. Then most of the manufacturers offer little courses on, for lack of a better term, dummy eyes or fake eyes, on how to use these materials. But I think that if you're going to do GAT, I would try to get an instrument, a smooth thing, and just touch the trabecular meshwork. Find out where it is. There's a Seiko is making, which is an American instrument company, something that basically scrubs the trabecular meshwork. If you email me, it's called the Taneko, Taneko, something. And it basically just goes along the trabecular meshwork. And it's just an instrument that seems to work very well. It was developed by Dr. Taneko in Japan. And that seems to work very well. And you can practice with these instruments, and you may be able to lower IOP by just doing that. Okay, so I would gradually get into the mode of you're getting into the trabecular meshwork.
Okay, I think that's very, very helpful. So one question that I have for the panelists, and of course, Dr. Robin, is that when we do the cataract surgery, I think there is some IOP lowering that automatically happens during the cataract surgery. So when do you think about combining the cataract surgery with another, like a glaucoma procedure? Which are those patients? What are the indications? And where would you do a glaucoma with the trab versus a glaucoma with, let's say, a MIGS?
For mild glaucoma,
Yeah, go ahead, Dr. Hussain.
for mild glaucomas, we can it's an open angle glaucoma on a single drug. You can just discuss with the patient, empower him to take the decision of just doing a phacoemulsification surgery, and then with an informed decision, you can just do a phaco, with a condition that he may require to use the medications even after the surgery. But suppose if patient is on multiple medications, then that forms an indication to couple it with the glaucoma procedure. MIGS, as of now, it's only for early disease, but when you have moderate to advanced disease, you have to do a conventional glaucoma surgery, be it a trabeculectomy or a valve surgery, depending upon the indication.
Okay. Okay. So, I think one of the things that at least cataract surgeons need to also understand here is that which are the surgeries that they can do themselves and where do they require the help from their glaucoma colleagues. So what is your sense, Dr. Hussain and Dr. Braganza? Can a good cataract surgeon actually do a good cataract surgery plus a glaucoma surgery combined together, or is it always good to work in teams along with the glaucoma surgeon?
I'm not terribly in favor of over specializing in saying that only glaucoma surgeons should do glaucoma surgery and only cataract surgeons do cataract surgery and things like that. But let me just put this problem in perspective. I have not yet had a glaucoma patient on treatment who has undergone cataract surgery in whom I have been able to stop or even reduce by one medication the drugs that he is using to control his intraocular pressure. Okay? Cataract surgery does reduce intraocular pressure, but not to any great level where you've got the kind of therapeutic reduction that you need for glaucoma. So you can ignore the amount that cataract surgery is going to reduce the intraocular pressure when you're making your decision about whether to do a combined procedure or not. And what Dr. Hussain said was absolutely, what most glaucoma specialists would follow. If you have a patient controlled on one drug and is compliant, and it's not a very advanced glaucoma, then you're fine doing just a cataract surgery. But if you've got a situation more than that, and don't forget that glaucoma medications also are an economic burden for our patients. If you've got something more than that going on, it's probably worthwhile including a trabeculectomy with your glaucoma surgery, with your cataract surgery. And we now have the option of possibly reducing the number of medications or maybe eliminating the medications with a MIGS procedure if the patient can afford it, because the MIGS procedure would need a device. Now, how the GAT procedure, the ab internal goniotomy procedure would fit in with a phacoemulsification, I'm not too sure, but I think it would. So that's again an option. And as Dr. Alan Robbins said, we have a lot more options open to us, and we need to sort of get a little more data so that we are clearer about where each of these options would lead us and what benefits they would provide to our patients.
I agree with everything.
That's a very...
And I'd like to add that, we're dealing with personalized medicine. Every patient is different from a cost, socioeconomic, the stage of the disease, their ability to get medication. So I think when a surgeon considers surgery, one has to think about all of these. In addition, one has to remember that all of both the Hydrus and the iStent were compared to cataract surgery. They were intentionally done at the time of cataract surgery. There are really no good studies of them done in phakic eyes. GAT has been done in phakic eyes. The Cohope dual bead surgery has been done in phakic eyes. But I can say you were asking whether or not you should do these and should a cataract surgery surgeon do them. And one of the things that I've seen in my practice is a lot of my patients who come in having had eye stents were placed in the ciliary body, were placed in the corneal endothelium. So there's a real knowledge of anatomy is very, very important.
I think probably that speaks that who should be doing it. So yeah, we have one last, before we conclude today's session, we have one question from one of the audience. Is that what's the experience of the panelists and the speaker in the use of other modalities other than mitomycin during the surgery, for example, 5-fluorouracil?
Well, I've never used 5FU intraoperatively. I've always used mitomycin intraoperatively. I've used 5FU postoperatively when needling a bleb and things like that. I have now shifted to using mitomycin even for needling. So, because 5FU, if it gets into the anterior chamber, does tend to cause an extremely severe uveitis and a lot of problems, whereas mitomycin is not associated with that much of those many complications if a little bit of it gets into the anterior chamber. In fact, the sclera and the cornea are really no barrier to mitomycin. It just crosses over quite freely. So I would prefer to just stick with mitomycin.
Yeah, I agree.
Dr. Robin, do you have any different experience?
Yeah, I mean, I have tried 5FU and I've used it post-operatively, but not intraoperatively, occasionally. But I don't think there's really, one of the slides I showed that hardly anybody uses in the US 5FU anymore intraoperatively or perioperatively. I'm not impressed that much with the Ologen. I think it has a role, but I haven't been impressed personally with it, so I've given it up. I saw it first used in India, and I brought it back home. It was available here, wasn't impressed. And I think that there's some good data now that injecting mitomycin rather than using sponges may be equally effective, but that's just a technique, not a big difference. I think mitomycin is currently the way to go. Hopefully better things will be produced in the future.
I would like to add that in addition to use of mitomycin, I have shifted over to the injecting form, as Dr. ALAN has said. That reduces the chance of blood leakage. If you are using sponges, the chance of blood leakage will be more. So if you are injecting in the fornix half an hour before the surgery, spreading it evenly, and then operate on the patient after half an hour, that helps. And second technique, which would also modify the bleb formation, is the use of releasable sutures that I find in my personal practice that helps us a lot to titrate the pressures post-operatively.
Yeah, I agree.
Very, very interesting. Okay, great. Are there any last messages for the audience from the speaker or the panelists?
My last message is I appreciate the opportunity to talk. I think this is a very good symposium and the panelists were excellent. And thank you, Dr. VANDANA. But I think also this is a great time for glaucoma as retina changed with all the anti-VEGFs and cornea changed with the use of DSEC. I think this is a new time for glaucoma. We're at the beginning. We're infants. We're not even teenagers yet. But I think it's an exciting time for people to think about glaucoma.
Wow, that's actually wonderful. The context that you've given, it is fantastic. Anything from you, Dr. Braganza and Dr. HUSSAIN?
I would just say, keep practicing gonioscopy. It's going to be useful.
A 4-mirror.
A 4-mirror. Okay, so practice, guys, all those who are listening, please practice gonioscopy with a 4-mirror and also practice gonioscopy intraoperatively post your cataract surgery. So get used to identify your structures well, and probably that will be a step in the direction of learning and mastering MIGS. With that, I'd like to thank Dr. Robin for giving us such an amazing information. This was a fantastic lecture, Dr. Robin. We learned a lot. It was early morning for you, so we really appreciate you making time. And thank you, Dr. Braganza and Dr. HUSSAIN, for helping us understand this in the context of our own country. And we look forward to having this device being adopted in our country in the future. Thank you all for making time.
Thank you.
Thank you.